would like to welcome everybody to this ERA ED meeting. This is organized by the EuDial Working Group of ERA, and it encourages research, education, improve the outcome for chronic kidney disease patients by enhancing the quality of the other therapies. Good evening to those in Europe, and good morning to those in the United States, and good day and good night to all others. My name is Frank van der Sande. I'm an international nephrologist working at Maastricht University Medical Center. I'm delighted to be the moderator in this seminar dealing with hemodialysis in the elderly, which type of vascular access to choose. And together with me is David Shemesh, who is director of the Vascular Access Center in Shara. The Medical Center is affiliated at the Hebrew Medical Center in Jerusalem, and the current president of the Vascular Access Society. And before moving forward, I want to inform you that by participating live, participants will earn 1 European credit for the continuous medical education. And this is an exclusive benefit for ERA members. This evening, we have 2 excellent speakers that contribute knowledge to the seminar. And we will start with Professor Joris Rotmans, a nephrologist and head of the Department of Nephrology of the Leiden University Medical Center in the Netherlands. And since his PhD, his research is focused on vascular access for hemodialysis. He did postdoctoral research on vascular tissue engineering at the Australian Institute of Bioengineering and Nanotechnology in Brisbane, Australia. And since 2010, he combines clinical work as international nephrologist with vascular and renal research at the Leiden University Medical Center. Professor Rotmans is head of the program for nephrology and president-elect of the Vascular Access Society. And next we have Dr. Maarten, which is the clinical lead of vascular access surgery at Maastricht University in the Netherlands. His main clinical and scientific interests are vascular access surgery and kidney transplantation. Maastricht University Medical Center is the national referral center for complex vascular access surgery, of which he is the clinical lead. In addition, he trained as a clinical epidemiologist. David, to you.
Yeah, thank you, Frank. We also have 2 excellent panelists. Tamara Jemcov is an assistant professor of internal medicine nephrologist and the head of a nephrology department in Belgrade, Serbia, with expertise in ultrasonography. The second panelist is Gaetano Alfano from Italy. He is a nephrologist at the University Hospital of Modena, Italy. He is a director of home dialysis program, and his expertise is dialysis and kidney transplantation. Now that we have introduced everyone, we can move forward with the presentation, and then we will have a discussion with the speakers and panelists for 10 minutes. There are also 10 to 20 minutes that are allocated for the audience questions. So please type your questions into the chat, and we will try to answer as many questions as we can before the time is up. Thank you so much for joining us today. Enjoy the seminar. The first presentation is by Joris Rotmans.
Well, thank you very much, David and Frank, for the introduction and your guidance during this webinar. And I'm very pleased to be able to participate to this webinar, because I do think that vascular access, and particularly for elderly patients, is a very important topic to discuss. And there's much debate about it. And the aim of my presentation, together with Maarten's, is to illustrate several factors that are involved in decision-making about vascular access for the elderly. I have, not that much conflicts of interest. The only thing is that I'm involved in a clinical trial for vascular access in the elderly, which Maarten is the PI. It's the OASIS trial. We will discuss that today. And as already mentioned, I'm a board member of the Vascular Access Society. Now, I would like to start my presentation with a case. In this case, an 80-year-old male patient with diabetic nephropathy who experienced a decline in kidney function in the last 3 years from 24 to 17 mL per minute. He has a quite extensive medical history with type 2 diabetes, hypertension, stroke, and impaired cardiac function, and also peripheral arterial disease. Clinically, he's doing relatively okay. He's HDL independent. He doesn't have any uremic symptoms apart from fatigueness. He has a relatively normal weight, a little bit higher blood pressure, and there's currently no signs of fluid overload. As a good nephrologist, you discuss with the patient the types that are present, the options that are available for renal replacement therapy. And the patient, together with the patient, you decide that when needed, hemodialysis is the treatment option that the patient prefers. So based on the current guidelines that were updated in 2019, patient with an eGFR between 15 and 20 ml should be referred for assessment for dialysis access. So what's been done is there's a duplex being made, which shows actually that in neither of the arms a radiocephalic fistula is possible because of too small veins, but in both arms a brachiocephalic fistula is a possible option. And then my question to you as participants to this webinar would be, and there will be a poll option present shortly, what would you advise this patient to do? Would you refer him now for a brachiocephalic fistula? Or the second option, would you refer the patient 2 weeks prior to the anticipated start of dialysis for an arteriovenous graft, potentially an early cannulation graft? Or would you place a tunneled catheter at the time of hemodialysis initiation? Or is it just a too complex case where you don't have a clear preference? And I would like to give you now some time to raise your voice and select one of these options. So it's an 80-year-old patient in a pre-dialysis phase with a clearance of 17, with a quite extensive cardiovascular medical history and no options for radiocephalic fistula. Well, that's interesting results from my perspective. Most of you, actually 62%, refer the patient at the moment for a brachiocephalic fistula. Then another group of 21% places a tunneled catheter at time of dialysis initiation, and a similar group actually refers the patient for an early cannulation grafts, also close to the anticipated start of dialysis. So in summary, most of you refer the patient for brachiocephalic fistula. Well, and the question is indeed, is that the right option to choose? And I would like to stimulate you to think about this, maybe a bit difficult question, but how convinced are you actually, in particular the ones that choose for brachiocephalic fistula, that this is the best option for the patient? Do you have doubt, or are you sure? And try to score yourself somewhere between 0 and 10, where 0 is that you're very unsure, and 10 is that you're 100% sure that the brachiocephalic is the best option in your opinion for this patient. Right, so most of you are quite convinced, or actually in the upper level, somewhere between 5 and 10. So well, my aim is to make you a bit more unsure, to be honest, about your preference, because I think there's a lot of debate and various options could be suitable for this patient. Well, you know that there are multiple current limitations of access, the modalities that we have present for AVFs. It's primarily non-maturation, which can be very substantial, as I'll show you in the subsequent slides. For arteriovenous grafts, it's primarily the formation of stenotic lesions in the venous outflow tract. And for central venous catheters, it's primarily infections, but in the recent years, even more important thrombotic complications of central venous catheters. And as you might be aware of, based on the KDOQI guidelines that I already mentioned, there is quite a paradigm shift going on in vascular access. And that the statement of fistula first, catheter last has been changed into a new statement, which is summarized as the right access for the right patient at the right time. In other words, leaving options for other types of access than fistulas for selected patients for which radius fistulas might not be the best option. And it's really important to take the whole career, the future career of a patient into account for selecting the optimal access for that patient at that time. And as you know, the history of vascular access is well, from the last century, and this the first publication about the radiocephalic fistula is from 1966 in New England. So more than almost 60 years, we utilize the same type of access as a preferred option. But it's good to realize that when these three doctors designed this radiocephalic fistula, the average age of patients was much, much lower. was in the range of 40 years, 40 to 50 maximum. And for the elderly patients, dialysis was just not a accessible option. As you can see here in one of the papers from that paper in the 1960s, I highlighted in red on the left that the age of the patients was, well, you see 37, 38, 28, 40. None of the patients, oh, actually the first patient was above 50. And the outcomes, the complications there were still complications. So there's also here fistula that did never function, but on average, the outcomes were quite good. And that is one of the reasons why, of course, we all feel and felt that fistulas are the best option for access. But since then, in the last 60 years or so, there's a dramatic change in the dialysis population. While in the past, patients were relatively young with isolated kidney disease and minor comorbidities and few cardiovascular events prior to dialysis, the current days, the elderly population are the vast majority of patients on dialysis. They have systemic disease, cardiovascular disease to a very large extent, also prior to the initiation of dialysis. And they might also have a different goal on dialysis, with a more focus on quality of life than on survival, which is, as you all know, usually far more dominant in the young patients. And this is a slide from the US showing indeed that there's a dramatic change in the age of the dialysis populations over the last decades. Well, actually, since the 1980s, the patient groups of 65 years and older are now the vast majority of patients on dialysis. So this is in the US, but the same is true. This is from the Netherlands, of course, much smaller numbers, but the picture is the same, that more than 50% of the dialysis patients are 65 years and older. So in decision-making about the best access for these patients, there are a couple of questions that I would like to address. Especially in these preemptive patients, the question is, how long will it take before dialysis is indicated? How big is the chance that the patient will die before dialysis initiation? Because if that will happen, all the work for creating the brachiocephalic fistula is not very useful. What's the prognosis of these patients on hemodialysis? And what's the optimal access, of course, for this patient? And very important, what about patient preferences? Because that might be very different from the doctor's preferences. And we were treating the patient, right, not ourselves. So what about the rate of decline of kidney function in the elderly? And well, we all know from our daily practice that it's quite difficult to predict, but studies that have tried that actually show that in the elderly, the rate of decline of GFR goes much slower than in younger patients. And in this example of a cohort of 11,000 patients with a clearance of 17 mLs per minute as our patients, with a 1 year of follow-up, the average decline for patients with 80 years is 2 mLs per minute, while it's, as you can see here, higher in the young patients, which means that on average, after 1 year, his clearance will be 15, after 2 years, it will be 13, and so on. And here you can see the chance of initiating dialysis within 1 year for the same group of patients. So again, for patients with the age of 80 years old, only 20% initiated dialysis after 1 year. So if you now refer patients for a brachiocephalic fistula, the chance that he will need the fistula in the next year is only 20%. So what about the prognosis of patients once they initiated dialysis? And again, it's quite difficult on the individual level to predict that prognosis, but there are some tools available that can provide some guidance here. And if you use this online calculator for the specific patient that I presented, the estimated risk of death within 6 months after initiation of dialysis is about 30%. So quite high, I would say. And also there are other predictors available. And with this predictors validated by Duceau, it shows that at 1 year, only 60% of the dialysis patient is still alive. So what about non-maturation for these patients? So we all learn what non-maturation is an issue, but if we inform patients, we say, well, the rule of 6 is after 6 weeks, the fistula can be used, and of course it can go wrong. But at least in our hands in the Netherlands, outcomes are with regard to non-maturation are quite worrisome. So after 6 weeks after AVF surgery for the radiocephalics, but also for the brachiocephalics, the cannulation rate is only 20%. And this was for patients that are already on hemodialysis. So they had already a need for a good access. At 3 months, it's only 60%. And at half a year, it's 75%, which means that 25% of these fistulas is never being used for dialysis. And that number is a little bit lower for brachiocephalics, but it's still in the range of 20%. And various meta-analyses and studies have shown that the primary failure rate in the elderly is actually higher than in the younger population. And I apologize for this very unsharp slide. It's from the paper and the Journal of Vascular Surgery, but the message is clear, is that in this meta-analysis, the risk for primary failure of fistulas is about 80% higher in the elderly. There are also being other meta-analysis being performed, and the one by Belsma is a very well-known one. It's a very huge study showing that indeed in the patients of 65 years and older, 29% of the fistulas will never be used, are being abandoned prior to hemodialysis initiation, which is about 50% higher than in the overall population. So the elderly are at higher risk of complications of fistulas in general. And also 1 year failure rates in the elderly are worse. Here again, the same meta-analysis, 60% increase in failure rate at 1 year after dialysis initiation. So what about patient preferences then? Because well, what is actually the most important for patients? And that's a difficult question. But this slide shows that the perspective of healthcare professionals and patients differ quite substantially. And if you look, for instance, on the item where doctors and patients differ the most, it's about mortality. Healthcare professionals think that mortality for patients is far more important than the patients consider that for themselves. They want to have the ability to travel, to be not in the hospital. So focusing on mortality rates for dialysis access conducts, the question is if that's really the most important endpoint for patients in those studies. And Maarten will discuss that as well in his presentation. Another issue to take into account is that with the increasing age of the dialysis populations, we do see more and more that patients themselves decide to stop dialysis. And in the Netherlands, and it's quite striking when I read this paper recently, it's actually the most common cause of death in the dialysis population. So more than 20% of the patients on dialysis decide themselves to stop, in particular already in the first year. And not surprisingly, that's particularly in the elderly, where the risk for patients above 80 to stop dialysis themselves is 2.5-fold higher than in the patients below 60. So that is a common issue, and it illustrates that indeed mortality or the length of life is for a substantial proportion of the patients not the most important. If you then look to the patient perspective on access, it has not been studied extensively, but this is a study that illustrates also that for elderly, it might be a bit different than for younger patients. For the patients below 65 years of age, they have more access-related symptoms when utilizing a catheter, as shown on the left part. But in the elderly, it's the opposite. Then patients experience more complications or more symptoms from their arteriovenous access compared to the catheter. For them, it might be less important to be able to swim and so on, as an example. So that is something to take into account in decision making. And of course, as I already mentioned, there are quite some differences between countries and centers. And in this slide, I try to summarize a couple of them. Because of course, with your ideas about how bad catheters are, it is strongly influenced by the complication rate of catheters in your country or in your center. And they vary a lot between centers. And especially in the last couple of years, also in the COVID era, it has been shown that the infectious complication rates of catheters might be much lower, are actually much lower than in most of the studies that has been published in the past. So it's not uncommon to have catheter-related infection rates sort of below 0.3 per 1,000 catheter days, which is really low. And of course, it also relates to cannulation practices. It matters a lot if you are trained as a dialysis nurse for 4 weeks or for 1.5 years to reduce complication rates of catheters. So, and all these factors are important in decision-making which access is the best for your patients in your center. And of course, as I mentioned, the cultural aspects related to whether or not to stop dialysis or to focus on survival or quality of life is the factor that differs a lot between countries and makes it very difficult to come up with a solution or a selection of access that is the best for patients all over the world. So we need to take all these factors into account. With that, I would like to come to my conclusions. That about 30% of the fistulas placed in the elderly is never used for dialysis, and that's a substantial proportion. Patency of AVFs is lower in the elderly. The perspective of patients might differ substantially from the doctors, in particular in the elderly, and the preferred type of access for elderly patients remains an individualized decision. And with that, I would like to thank you for listening and give the floor to Maarten for his presentation.
Thank you very much, Joris. My name is Maarten Snoeijs. I'm a vascular surgeon working in Maastricht University Medical Center. I'm also the principal investigator of the OASIS trial, which is a randomized controlled trial comparing fistulas, grafts, and catheters in the elderly patients starting hemodialysis treatment that is currently enrolling patients in the Netherlands. Well, in this presentation, it's actually a succession of the presentation you just saw given by Professor Rotmans. I would like to show you that the available evidence that does not lead to strong recommendations for any particular type of vascular access in elderly patients starting hemodialysis treatment. I think Professor Rotmans has gone in depth into the advantages and disadvantages of fistulas in the elderly. I think that we can summarize this by stating that when these fistulas mature and become functional, they have few long-term complications, but maturation takes time and may not happen at all in a substantial proportion of patients. When we take another look at the arteriovenous grafts, an advantage of the grafts is that they can be used immediately after surgery. And this is an advantage, especially in the elderly who are still in their pre-dialysis phase, because this means that we can postpone surgery until hemodialysis is really indicated. And as you saw in the previous presentation, given the prognosis of these patients, when fistulas are being created early, a substantial proportion of the patients may in fact die before hemodialysis is needed. And in these patients, a fistula would have been made unnecessary, and grafts can be a strategy to overcome this problem. Of course, grafts are associated with disadvantages, especially more stenosis and thrombosis in the long run. However, the survival prognosis of these patients, of the elderly, is typically not very long, and one can accept the increased risk of stenosis and thrombosis in the future and take the advantage of the preventing early complications with the fistulas. A final option that can be done is the dialysis catheters, the central venous catheters. A major advantage from the patient perspective is that no cannulation is required. So there's no pain, no fear for needles, no compression of the cannulation sites when the dialysis session is over. From a patient perspective, this can be very important. Of course, catheters are associated with an increased risk of infection and mortality in observational studies. We will go into more depth into the problems with the catheter infection later in this presentation, but it seems that in the recently published randomized trials, the catheter infection rate is actually rather small. And one may say that from this perspective, thoracic central venous obstruction caused by catheters may be more of a problem when these catheters are being used in infection. Especially in younger patients, this can be it can be very difficult to provide hemodialysis with the central venous obstruction, but again in the elderly with a much less emphasis on having a prolonged vascular access and having all possibilities for vascular access in the future available. I think with these elderly people, catheters, the long-term problems that might occur because of central vein obstruction may be less of a disadvantage in the elderly as compared to younger patients. So I think it follows from this discussion that the balance between the advantages and disadvantages of the different types of vascular access strongly depends on the life expectancy of the patient. For young patients, I think we would advise to create a distal arteriovenous fistula and accept the risk of additional interventions now, because this strategy will lead to benefits in the future by preserving vascular access options and by creating a durable vascular access once maturation has been achieved. But for elderly patients, this choice is not so clear, and the evidence currently does not lead to a strong recommendation for any specific type of vascular access. And I think this is precisely what is meant by creating the right access for the right patient at the right time. So what is wrong with the observational studies on vascular access for hemodialysis that were the foundations of the clinical guidelines of the past that stated that fistulas should be always the first option and catheters should be the last solution for these patients? Well, the core problem with these studies is the risk of bias, which means that problems in the study design may lead to results that are systematically different from truth. And I would like to explain this problem of bias by several examples from the vascular access literature. The first example is derived from an observational study comparing the survival of patients who start hemodialysis with a fistula and with a catheter. And these are all elderly patients aged 65 or older. The groups of patients are very different because patients who start with a catheter, they have to start urgently because of severe illness and may not even have nephrology care in the past. Whereas patients who can start with a fistula have had sufficient quality of blood vessels to be selected for arteriovenous fistula creation and also had successful maturation of their arteriovenous fistulas. So in this slide, you can see that the survival of the elderly patient starting with a fistula, that's group 1, is much better than the patient who start with a catheter. And it is important to realize now that this difference cannot be attributed to the catheter per se, because of the differences in the patient populations, in the patient characteristics between these groups. In this study, this was elegantly shown by including a separate group of patients, group 2, who started with a catheter, but who were selected to have arteriovenous fistula surgery. But the fistula was not ready for use at the time of dialysis start. So the selection process of these patients for arteriovenous fistula creation, you can see that this led to a prognosis of these patients which was much more similar to group 1, the patients who started with the fistula, then group 3, the patients who started with the central venous catheter without previous fistula surgery. So even though the patients in group 2 were using the same catheters as in group 3. So this selection process may have caused about 2/3 of the prognosis difference in this observational study. What about the infection rates with central venous catheters when mortality seems to be largely, the mortality difference seems to be largely attributable to selection bias? Well, the infection rates in recent randomized clinical trials has been quite low, a lot lower than reported in previous times. A multi-center randomized clinical trial, one of the largest that have been reported with respect to infection prevention in central venous catheters for hemodialysis, the ClearGuard trial from the United States, in the run-in period, so where no special precautions were taken for infection prevention, 1.0 catheter-related bloodstream infection per 1,000 catheter days occurred. In the more recent reduction trial in Australia, in the baseline risk without any special infection prevention measures was 0.3 catheter-related bloodstream infection per 1,000 catheter days. Well, with this incidence rate, well, the risk of mortality for the elderly patients who are on hemodialysis is probably higher than the median time until a catheter-related infection in these patients. Another important observation during the COVID pandemic was that strict infection prevention measures were reducing the catheter-related bloodstream infection in a lot of units throughout the world. With respect to catheter infections in the elderly, it seems that patients over 70 years of age are maybe have less risk of infection than the general population on catheter dialysis. In an observational study, both in Canada and in the Netherlands, the risk of catheter-related infection was about 30% less in elderly people when compared to younger patients. Another problem with these observational studies on vascular access for hemodialysis is when the patients are followed at the start of dialysis treatment rather than at vascular access creation. Here you can see an observational study comparing vascular access prognosis, the survival of the vascular access, comparing fistulas with arteriovenous grafts. And as you can see, when we take a look at the time, when we start the observation at the time dialysis is started, grafts have a much worse prognosis as compared to fistulas over the entire 10-year course of this observational study. Please realize that the starting point of this study is hemodialysis start, when both the fistula and the grafts were functional. And when we instead take another viewpoint, at the time vascular access was created, before hemodialysis started in this study, the picture changes completely. Grafts have a similar prognosis as fistulas, and in the first 2 years after vascular access creation, grafts actually do better than fistula creation. And for elderly people starting hemodialysis treatment, a median life expectancy of about 2 years is very common. A final example of selection bias in observational studies on vascular access is when when dialysis registries are used. Registries are, of course, very important in these observational studies because of their large sample size. We can have very precise estimates of the effect sizes. But the problem is that only dialysis patients are included. And when fistulas are created in patients before they start hemodialysis treatment, these patients will not be inside these studies. And the patients who die before they use hemodialysis, this problem with fistulas is completely out of the picture in these studies. So, these examples of bias in observational studies show that guideline recommendations to create distal arteriovenous fistulas as the preferred vascular access for all hemodialysis patients have a very weak evidence base. The balance between the advantages and disadvantages of fistulas, grafts, and catheters changes with patient age and life expectancy. In elderly patients with a relatively short life expectancy, the choice of vascular access can be adjusted to the preference of individual patients. Randomized clinical trials are needed to have better input for this process of shared decision-making. In the next 2 slides, I will conclude my presentation by presenting an overview of ongoing randomized clinical trials comparing different vascular access strategies in elderly patients. The Access HD randomized clinical trial is currently recruiting patients in Canada and in Australia who have already started with hemodialysis treatment on a catheter and are aged 50 years or older. And these patients are being randomized to arteriovenous fistula creation or continued catheter use. The Austria trial has just started including patients in Austria and Germany, and are including patients aged 60 years or older, and randomizes these patients either before or after start of dialysis treatment to arteriovenous fistula and catheter use. The OASIS trial is a Dutch trial that has now included approximately 40% of the intended sample size and are randomizing patients who are aged 70 years or older to arteriovenous fistula, arteriovenous graft placement, and central venous catheter use. Patients can join the study either when they are expected to start hemodialysis within 6 months, or they have started dialysis treatment on a catheter urgently in the past 6 months. Then there are also two trials that are comparing fistulas with grafts. The elderly trial is a trial in the United States based in Houston. They are randomizing patients to fistula or graft creation who are aged 70 years or older. This trial has actually been ended prematurely because of financial problems during the COVID pandemic and because of slow recruitment. The Access trial is a multi-center US-based trial that has just started enrolling patients and are enrolling patients 65 years or older and are randomizing these patients to fistula creation or graft placement. Well, I hope you enjoyed listening to these presentations on vascular access creation in elderly hemodialysis patients. And Professor Rotmans and I look forward to taking questions and discussing the subject with the panelists.
Okay, thank you so much, Joris and Maarten. Excellent presentation. Now the panelists will have 10-minute discussion with the speakers. At the end of the discussion, we will go ahead and take questions via the chat. So for those of you, the audience who turned in late, please submit your questions to the chat and we will get them as many as possible we can.
Thank you. Thank you both speakers. It was very, very nice lectures, and that we can make questions to ourselves, not only to the audience, and what are we doing in our practice. Especially when we are talking about elderly population, when the progression of CKD is slower in the elderly, and which give us an argument for the strategy watch and wait, and to make the decision to start hemodialysis when it's really unavoidable and urgent. And in the light of that, I think by myself that maybe the central venous catheter might be the optimal option in this situation. And what do you think, Gaetano, about this? What do you think in Italy? What is the praxis in patients who are older than 65 years?
Okay, thank you for the question. In Italy, in our center, we have no limits, no barrier for the access to hemodialysis, and in our center that take care of 250 patients on hemodialysis, more than 50% is over than 65 years old, and about 30% of patients it's over 80 years. And in this population, it's inevitable that there is a high grade of catheter. So from presentation of Maarten and Joris, we have now we know that the catheter is not the devil for hemodialysis patients. When we have patients, we have to consider characteristic of the vessel, patient's comorbidities, health circumstances, and also the patient's plan for his life. So it's inevitable that the patients that are referred to our center have a lot of comorbidities, and in especially heart and peripheral and vascular comorbidities. And patients with the coronary artery disease and with peripheral artery disease is increasing. So in these patients, distal arteriovenous fistula, it's impossible to place and to create. And so we are forced to think in a different way. There is a paradigm shift from the first dialysis first to the right access for the right patients. But maybe the most important thing is to first of all speak with patients, understand what is his preferences, what are his preferences and his expectations of the life, and also to consider the comorbidities. Patient with heart disease, with a low ejection fraction, or with also with peripheral artery disease, are not amenable to fistula, because they, from my point of view, primum moments non nocere. So, okay, we have to create the best access for a patient that the first step is to not harm the patients with an access that has a high grade of failure, but in some patients, this access can also harm the patients. And this is my point of view about this very tricky and challenging argument, because planning vascular access in all the patients, it's not easy. And what happened at many questions arise, because sometimes we have not the right answer to the question of the elderly patients on hemodialysis, or the elderly patients that is referred to surgeon or to a multidisciplinary team with expertise on vascular access.
And we should also think about their wish, about their interests. Elderly patients also, and as we can see from the Professor Rotmans' presentation, there is a totally different perspective of the doctor's point of view and also the patient point of view. What is important for them? The patients think that for them it's important to have the free dialysis time, and they have some hobbies, or some wish to travel, or in the elderly they want to meet with their friends and to have a chess and to have a coffee and a talk, or to sit in the park. So and also to something which is not painful, like it is puncturing of AV fistula. I think it is also one of the reasons of which we can talk about it and to think about it. And also if we think that the progression of CKD in the elderly is much slower than in the younger patient, also we can really maybe we can think about this strategy to watch and wait, and just to to have the more control examination of our patients, and just to leave them till the time when we just need to start the hemodialysis, not to make the vascular access, which won't be which won't be matured, or which won't be used because of the patient age. And maybe we should, in that point of view, maybe we should think about to redefine what is the best vascular access. So what do you think? Is the AV fistula still the best vascular access after the more than 50 years after the famous trio created radiocephalic AV fistula? Is still a native radiocephalic AV fistula the best vascular access after these 50 years of the first creation? Should we redefine our point of view about the best vascular access?
Yeah, well, that's a very good question, Tamara, and if I may try to give an answer, I think in general the answer is still yes. But for the elderly, I think based on the data that we've shown, that the real answer is that we don't know, and that indeed these kind of trials are needed to find out on different kind of outcome parameters, like quality of life, like numbers of interventions, and costs, of course, are also very important, which type of access is the best. And still, this trial can also definitely reveal that there is no clear answer, right? That it depends still on patient characteristic for which groups, which type of access is the best. So, but I think it's important that this discussion opens the option that you don't feel ashamed or reluctant to choose for another option than a fistula based on the discussion you have with the patient, and that we do not try to insert fistulas in all these patients per se. That I think is an important conclusion for me for today.
Okay, I really agree with you, and also I think that Maarten also I think that his presentation is in line with your presentation, and that he also raised some questions about failure of AV fistula and also infections, which is lower rate of infection in the elderly than it is in the younger patients. So we could think about this devil solution of a central venous catheter, that it's not even more devil. It's not the doctor. It's more Dr. Jekyll. It's not Mr. Hyde anymore.
Yeah, exactly.
In that, yeah. So.
And what I would
Tamara,
like to add,
if I may
yes.
respond to that,
yes.
Still in all the observational studies, the catheters have more mortality than fistulas and grafts. We assume that this is due to selection bias, at least for a large part, but this statement can only be proven by the randomized controlled trials that are currently being conducted. So I myself would still be a little bit hesitant to actually promote catheter use in the elderly until we have the results of these randomized controlled trials in our hands. Because we do have excellent alternatives for catheter use, that is fistulas and grafts. So I would, of course, when we discuss advantages and disadvantages of different options with our patients, a patient may choose for a catheter, which I think is fine, but as long as for patients who leave the decision with me, I personally would recommend rather a fistula or a graft than catheter use, because of this this continued mortality problem with in these observational studies.
Okay, thank you so much for the discussion. We must move on, so we are going to get questions from the chat. There are not many of them, and I ask the panel to give brief answer to get as many answers as we can. Frank?
Okay, there are a few questions from the chat, and the first one I want to ask you is what can be done to avoid more and more central venous catheters in elderly hemodialysis patients? But I think both of you gave beautiful answers to that, but that's one of the first questions from the chat.
Yeah, well, one remark I can make, I think what we definitely need is more research on improvements for catheters, because I do think we do a lot of studies on improving fistulas and grafts, but for catheters, the innovations are relatively staying behind, or there's some designs and configurations of the tips, but most catheters use the same kind of materials. And if you look to material sciences, there's so much happening. And I think we could learn much more about it to improve also the biocompatibility of catheters and reducing these thrombotic rates, because, well, as we mentioned, these thrombotic complications are actually currently more important than these infectious complications. And that's not a short answer on the short term, but that's well, a statement that I would like to make that we should focus on as well.
Thank you, Joris. And Maarten, your answer to that, because I was impressed by your last answer that maybe we should go first, perhaps indeed for an fistula graft, and the second choice, knowing that you were running the OASIS trial for a catheter.
Yes, but that is within the context of a randomized controlled trial with safety monitoring, and I think this is different from daily practice. How can we avoid catheters in the elderly? Well, I think that's good. It starts with the pre-dialysis care of the general practitioner, and who is to refer to the nephrologist, and the nephrologist who has to refer to the vascular surgeon. And well, then I think that one strategy that might be interesting if you want to prevent early fistula creation in patients who may not progress to dialysis treatment might be to create a early cannulation graft in 1 or 2 weeks before you actually have to start dialysis treatment. And it might help when a lot of centers, especially in Europe, do not use a lot grafts frequently, so they have little experience with that. I think that when you might gain some, it might be worthwhile to gain some more experience with these grafts in the elderly. At least in my hands, I think that we tend to have good outcomes, especially in the elderly people.
And perhaps a second question from the chat today: how successful are we in evolving from a fistula first to a right access, right patient, right time perspective? So what is the right time and the right access?
Well, the right time is probably relatively easy, is that the access is functional at the time dialysis is needed, and not half a year or a year before, and not half a year or a year after. And of course, it's difficult to predict. But the right access in general, I don't think that there's an answer there, which is the right access. So, but that's an individualized decision. One of the limitations in a couple of countries still is, with regard to this question, is in evolving from a fistula first approach, is that there are still countries where the percentage of patients that utilize a fistula is a quality parameter, and sometimes even reimbursement rates for dialysis access are related to the percentage of patients with a fistula. And that actually, of course, to some extent could limit the freedom doctors and patients feel to choose for other options.
But I think that mentioned also the right time of referral, as Maarten already mentioned, when patients are seen earlier, referred to a nephrologist and early referred to a surgeon, then the right decision can be taken, which access is for these patients the right one.
Yeah.
I think that the decision should be the result of the few sides, not just the patient. Patient should be educated about every type of vascular access and should be informed about his or her condition, about physical and psychic condition. So we should take it all these things into account, and also the surrounding of the patient, where he is living, and the local condition, as you also mentioned, Joris. It is very important where is this patient is living, and what we should expect about future vascular access, and also to what is the prediction of and what is the possibility to come to hemodialysis in next 1 or 2 years. So when we take into account also surgical point of view, nephrologist point of view, and also the patients, so this decision should be time. It should be the decision of all parts of the team.
Okay, Frank, should we finalize the session, the seminar?
Yes, because it's
Okay.
almost time, I think. Yes.
Do you have remarks or comments?
Yes, I have 2 comments or 3 comments. I think it's utmost important, as mentioned both by Maarten and Joris, the time of placement, time referral, time of placement, and what is optimal choice for the patient. I think the definition of elderly, as mentioned, 65 or 70, knowing nowadays that most patients are growing, getting older, that perhaps the elderly should be more above 75. And also looking at the infection rate in this patient, especially at higher age, they're doing better than young patients, as Maarten mentioned, and Joris mentioned. So I think perhaps above 75, a catheter in these patients could be an optimal choice, which is because I think they're more aware of possible infection as compared to younger patients.
Thank you, Frank. I have also some few comments. I mean, you were very modest with your comments. So in my view, like you said, first, when we are talking about elderly patient, we should consider patient older than 80 years. I think I am 67. I don't feel old, and I know that many people cannot do what I'm doing currently. So, and soon we will consider elderly patient as older than 90. So I think we will have it within 10 years. Secondly, in our practice, and we published it in JVS, we did 146 new accesses created. We had 88% autogenous access and 92% excess patency at 1 year. And you know that my friends like Nicola Pirozzi and Williams report 96% patency. And at that time, the median life expectancy of octogenarians was 38 months. And those patients can really enjoy this period of their life without CVC and with a fistula or the graft. So thirdly, when adequate preoperative planning and postoperative maintenance are carried out, maturation and patency, of course, are guaranteed. It is not the age that matters really, but the vessel quality that we choose. Fourth, the timing of access creation in the elderly patient is important and crucial, like Joris mentioned. And fifth, the KDOKI guidelines consider it reasonable to create heavy fistula with arteries and veins less than 2 millimeters. I think it's impossible. And this is why the Fistula First initiative failed in the United States, in my opinion. Practically, a minimum of 3 millimeter vein diameter is recommended in my center, in my view, for fistula creation, especially for the non-expert surgeons. And finally, age alone should not disqualify patients older than 80 from vascular access creation, nor should age disqualify this patient from the fistula creation. Do you want to close, or should I close?
Yes, please close, please. Yes, sure.
So I think we have reached to the end of our time. I think we want to thank all the speakers and the panelists for your excellent presentation in this seminar. Also, thanks to the audience and the EuDial working group, and especially to Federica. Thank you all. It was a real pleasure to do this seminar with you. Thank you.